Well, it's a pleasure to be here, and I went to McMaster where David Sackett taught for years. They created evidence-based medicine, then the Cochrane collaboration happened. For me, it was 1990. It wasn't even called evidence-based medicine yet. And I remember Dr. Sackett saying, you know, if all you do is write review papers, you're reading people, all they do is write review papers, don't listen to them. Because they're over the hill, you want to listen to people who are collecting new data. Now, so this is going to be a little tough because all I do is write review papers now. Okay, that's supposed to be a little ironic. But I didn't just stop doing data collection, I went into the clinic. And clinical data is valid information to make decisions. So that's where I came from, really, evidence-based medicine, and then two of my patients did a low-carb diet in 1998, so 24 years ago, and I was worried. I saw it work, but I thought maybe it was harmful, maybe it was bad, and so we started to do research. But I saw it in other people, and now, how many of you, this is 20-some years since I first was introduced to it. How many of you are kind of new and you might even not have started a low-carb diet yet? Raise your hand. Yeah, so you were grabbed here by your friends and said you have to come today. You don't want to be here? Yeah. Actually, Robert, escort him, please. There's only one. No. And how many of you have already started to eat a low-carb diet? Raise your hands, please. Look around. So you're not alone. We've started to do events in towns in the US like this, and hundreds of people will come out on a Saturday and even pay a little bit of money to come to be among their tribe. And does medical students, do you have any doubt that these people are not telling the truth? Right? So a low-carb diet can work. How many of you have lost weight using a low-carb diet? Raise your hand. Well, there's no evidence for this. No. Oh wait, I'm going to go over the randomized trials in just a minute. So clearly it works, but we had questions about safety. Was it healthy to do? So I've learned a lot. I've learned over the last couple of years how the internet can teach things in a bad way and a good way, and I'll give you some clarity about the science that we've collected through the years. Some of the difference I see, at least in the U.S., actually, some of you are here and have actually been involved in teaching from my company, Adapt Your Life. Raise your hands, please, if you've been in. So I'd like to be sure to get photos with you guys before you leave today. So that it's just wonderful to have that internet reach, which can be global, right? It's really kind of amazing. So I'm still in a clinic, though, Tuesday through Friday in Durham, North Carolina, and you don't have to see me there, but that's why I'm not an internet doctor. I'm not, you do see me on YouTube. So, no, anyway, how do you know who to believe? How do you know who to trust? And so I want to give you the real world, people around you having success with some of the science here, and then a little bit, I gave you the answer on this slide on how it all works. If you eat carbs, you have to burn carbs. We don't store carbs in our body, we store fat. So if you want to burn carbs, eat carbs. If you don't eat carbs, you burn fat. That's all you need to know about how a keto diet works. And that was first written about in London. You heard the Banting in the 1860s. And so this is nothing new. Ancestral health. Right, you know that. This is hunter-gatherer, ancestral health, kind of like the way maybe we were designed to eat, huh? Okay, let me make sure. There we go. So there I am. You might have seen me at Diet Doctor. I knew Andreas, the Diet Doctor, when he was a little baby, carrying his one camera onto the low-carb cruise. And now he has a group of photographers who come and do it. At Diet Doctor, I followed that. That's the film or the video in the upper left there. The Obesity Medicine Association is a group of doctors in the U.S. and who use this technique and other techniques to help people with obesity and other metabolic problems. I think this is the easiest and simplest way to do things, but I can prescribe medicines, and that's something for you to remember if you're having trouble and it's not working for you. Interesting, you heard the term adapt. All organisms have to adapt, and that's the name of my company that's trying to get this information to as many people as possible. Adapt your life. And then Amy Berger, another Amy Berger's great overlap shout out, helped to write End Your Carb Confusion, which is the cookbook and regular book out just now. I'm not going to talk about any of that. So let me take you back to 1998 in my office in Durham, North Carolina. I know nothing about nutrition. In the US, medical students maybe get an hour or two. I learned about nutrition in the intensive care unit in medical residency that had to do with total parenteral nutrition. So you either put nutrition in the gut or you put it in the vein, but that's all I knew about nutrition. So when these two people started, they lost 50 pounds each on their own without me. I thought, this is great. You don't need a doctor to lose weight. They did it just with food. And so I asked, how did you do it? And one guy said, all I did is eat steak and eggs. Steak and eggs. Steak and eggs. And, oh, come on. No, but I got to know these patients. I'm in a primary care, so internal medicine clinic. So I thought, well, that's interesting. Another patient came back, same thing. Lost 50 pounds on a low-carb diet. I went to the bookstore because there was nothing in it. I didn't go to the bookstore first. I went to the medical literature. And I found the only paper on low-carb diets within the last 20 years was written in 1980. And here was the evidence that nailed the coffin on high-fat diets, said it was bad and you shouldn't do it. That first one. There were 24 obese but otherwise normal men and women, and they followed the diet for 8 weeks. And they all lost weight. The triglycerides went down, but the LDL went up. No studies over the next 22 years. When Jeff Volek and I, in the same month in 2002, had papers coming out on a low-carb diet. I went back and talked to researchers in the US about this, and they said, they would stutter if you talked about a high-fat diet, and there was a taboo, meaning there was no law. You couldn't study a low-carb diet. There's no law. There's no rule. You can't. A taboo is kind of a socially accepted thing that you wouldn't do that. So there are no studies. Even to this day, I can't find but a few formally NIH, so governmentally designed and run studies that are really assessing this. It's changing now, but so I went to the medical literature. There was nothing. We did a review paper, and so then what would you do? Maybe you'd go visit. No, I wrote a letter to Dr. Atkins. He was the only one that had a clinic at the time using a low-carb diet, and I'm a practicing doctor doing clinical trials and evidence-based medicine. I'd visited Dr. Sackett and went to meetings he went to for years. Dr. Atkins calls back and says, what do you want? And I said, 2 of my patients did your diet, and they lost 50 pounds. And he was like, yeah. I said, well, you need to do research. And he says, why would I want to do research? I've been doing this 30 years in my office. I know what the research is going to be. I've been doing it. So I go to my colleagues at Duke and at the Durham Veterans Affairs, the Veterans Hospital there, and they say, what are you doing? Why are you talking to Dr. Atkins? He's this rich doctor up in New York City. He writes diet books, sells all this stuff. You'll never do research, right? Well, Dr. Atkins is the one who said, why don't you come to my office? Why don't you come see what we do? And so I took a little team to go visit. I say this to you. You come to Durham, North Carolina, and a few forms and things. You can sit in my office and see this work if you have any doubts. And I've done this to conferences of 600 doctors at a time. Welcome to come to my office anytime. You know how many people have come? Handful. No, not zero, but I can count, a handful. One of them was Dr. Sarah Hallberg. And I hope that, you get good feels about that. She came by, and I don't know how they came up with 30 grams for their protocols. I used 20. But anyway, I got to lay a little bit of, I think I helped Sarah figure out how to help the Virta Health company. But so, you know, okay, 2002, 50 people on a low-carb diet for 6 months, published in a peer-reviewed journal with, you know, good data. This is my minimal criteria. If you ask me, what about the DeVos diet? What about, oh, do you don't have one yet? What about the Dukan? What about the Dukan diet? What about the, I'm going to say, show me a paper in a peer-reviewed journal. 50 people, just 50 people over 6 months. Publish everything that you know in a peer-reviewed journal, and I'll read it, and I'll comment on it. Okay, we did that in 2002, okay? So you're going to hear, this is the minimal criteria to ignore all of the stuff you hear out there. Oh, you know, ketone drinks and all this stuff that's never been tested. So I'm going to teach you a low-carb, naming things is different. It's real food, keep the carbs super low, and there is a lot of data. In fact, when you line up all the randomized trials, ours is the Yancey paper, Yancey 2004. We didn't like collaborate together. These are all independently designed, independently run studies comparing low-fat diets to low-carb diets. Low-carb being, at the first phase, a ketogenic diet. That's why it's known as a keto diet, but we call it low-carb ketogenic in the literature in our papers. And now there are several meta-analyses done. Meta-analysis being a study of studies, and that bottom diamond, if it falls on the left-hand side of that line of identity, it basically means it favors the very low carbohydrate ketogenic diet. So for obesity, I mean, there are more studies about low carb diets than any other diets now. And I know you'll say, but what about the Mediterranean diet? Show me a paper, 6 months, in a peer-reviewed journal, you know, randomized trial, comparing it to anything else. I'll comment on it. What about the vegan diet? Show me a paper, randomized trial, comparing it to another. So I don't know how they get away with it. They say theirs is the best. They have never done a randomized trial of a keto diet versus a vegan diet. It's never been done. I'd love to do it. Oh, who's going to fund that? Well, we should, right? Or you tell them, you can't say it's the best diet. You never compared it. And, oh, what about the blue zone diets, right? You've heard of all of these books. There's no prospective data on any of those things. So my colleague, Will Yancey, who you've seen already on a very influential American Diabetes Association policy paper, he said to me, you know, Eric, gosh, the diet, it's really powerful. It's as good as a diet and a drug. And so, I don't know, Will, what do you mean? He said, so he took the veterans, these are people with diabetes, hypertension, they're on medicine, coming to medical clinics, the VA system in the US. And he showed basically that the low-carb diet was as good as the prevailing diet and a drug. Orlistat is a fat blocker, so that even if you ate some fat and a low-fat diet, it would block the fat and come out in your bowel movements. And there's a lot of like diarrhea and things like that. Not many doctors use Orlistat anymore. There are other medications. But anyway, so it's as good as a diet and a drug. Now, if you lined up all these studies, gave 1 point like a soccer, like a football match, or any kind of game, the low-carb diets here in the blue bar basically would win 31-0, comparing low-carb and low-fat diets. And this includes low-carb, not just keto diets. That's why there's so many there. But in the United States, there's a Food and Drug Administration that gives approval to drugs. They don't give approval to diets. Anyone can say anything about a diet, kind of freedom of speech thing. But if you put all of these papers together, it would surpass what's typically required for a drug approval. So if it were a drug, it would meet that criteria, which is pretty amazing. I mean, and to see that go from 1980, where there was 24 people basically no one would study it after that. And then Jeff Volek at UConn, now at Ohio State University in Columbus, Ohio, in our paper 2002, I thought by now the obesity crisis would be gone. So there's more than just presenting science. More than presenting science, there are other things that have to happen for these things to work. For example, are these guidelines, is this supported by organizations? I can happily tell you yes. So the Obesity Medicine Association has a very low carbohydrate diet, a very low calorie diet, meal replacement programs in their guidelines, because these are evidence-based guidelines. So yes, low carb diets are supported by the Obesity Medicine Association. Now switching to diabetes, this was another sort of back to the future sort of thing. I learned that Banting used the low carb diet for obesity in England, in London, had a little treatise on that. And then I learned that Osler and Frederick Allen and all these diabetes doctors were using a low carb diet to treat diabetes. Here in 1923, when there were no medicines available, insulin didn't make it into this textbook, it's 10 grams of carbs per day. And that's total, not net. They didn't do that. And so it's basically the same list of foods that I hand out to my patients today. And I give that kind of ironic look of, here's a new diet, and this book was given to me while I was doing my first study, and it came in handy because I was able to take it to the hospital director and say, oh, you don't want me to study this? Yeah, someone complained. Now, fortunately, I've never gotten into the hot water that Dr. Timothy Noakes got into. People argue that it's because the American system is more wrong-based. You have to show harm in the U.S. system. And that's why I think no doctor has gotten into trouble in the U.S. Not quite sure what the prevailing wisdom, if you're more in the Netherlands, more like South Africa, or more like the U.S. But I've never had a doctor in the U.S. go through that, at least tell me that story. Now, nurse practitioners I have. So we have a different tier of, you can be an MD or osteopathic trained. If you're following, you have to follow other people's guidelines. You don't have total control. You might be a little careful, or just make sure the doctor is going along with you. But even for diabetes, as you heard, there is now a paper that supports the use of low carb diets. And you can see that it took 2019 was the date of this paper. So we've gone from 1923, where this was used for the treatment of diabetes, and then it was vilified as you can't eat fat, it's terrible, it's going to kill you, to now, oh yeah, it's carbs that raise the blood sugar. Diabetes is a problem of elevated blood sugar. If you're going to change something in the diet to lower blood sugar, should you lower fat? If you're going to do something in the diet to keep the blood sugar down, are you going to restrict fat? No, you're going to restrict sugar. So this, it's like the mines were just thrown away. Well, problem is doctors don't have the template of nutrition treatment. And often we get trained by the medication treatment of things. So in the medical school, you might say, well, they're going to be using these medicines, SGLT2 inhibitors, which I'm not a big fan of. They've caused ketoacidosis in my patients. The whole idea is to have you urinate more glucose. And I'm just kind of, to have more glucose in your urine causes urine infections. Oh, they found those. So be careful with those medicines. But if you're a medical professional, you might say, I need to teach my students what they need to know with these medicines, for these medicines, and not so much for a diet. So for diabetes, the American Diabetes Association endorses it, and for now, yeah, we had to create a new Society of Metabolic Health Practitioners, because today, the power to fix chronic medical conditions lies in the hands of those in charge of the food. My secret weapon is food. And I can take people off 15 medications for diabetes, hypertension. So it's common to have 1, 2, 3, 4 medicines for diabetes. If you count how many shots of insulin a day, it might even be up to 10 shots with pills and shots. And then 4 medicines for hypertension. The list can go on, and the great thing is that all of these things can get better if you do an effective therapy like addressing the food. So this organization allows non-MDs, non-DOs to be a part of it. You can be a dietitian, and you can be part of the Society of Metabolic Health Practitioners. You can be a health coach and be part of the Society of Metabolic Health Practitioners, because the power lies in the food and lifestyle. And people come to me in wheelchairs and on gurneys, and so I'm not even mentioning the whole other aspects of healthy lifestyle because I don't need them. But I think those other things are good, of course, sleep, exercise, and activity. If you're trying to think, how do people get away with eating with what you know so far about carbs? They're all bad, no. If you have the right metabolism and you're exercising, if you live in this old city, Amsterdam, and you're biking everywhere, you can have carbs if your metabolism is that way, right? You don't have to have carbs. But so anyway, food is what we focus on in my clinic, because so many people can't even, they're using these wheelchair walkers, the roller walker sort of thing. So they can't exercise. But there's still hope, because all they have to do is change the food. So this is the clinical guideline for therapeutic carbohydrate restriction. And in the court of law, at least in the US, the judge is going to say, where is the guideline which covers your practice? Here it is. This covers you. There's an international organization that has this in their guideline. So the judge doesn't care. I mean, you'll get guidelines from surgeons that say, everyone needs an operation, right? You'll get a guideline from a keto group which says everyone needs a keto diet, right? But the judge doesn't care. They just want to make sure that you're doing something that's accepted by some group. So now back to a little bit of science, a little bit of what we do day to day. Obesity and type 2 diabetes have a common cause, and that's excessive dietary carbs. And that's because the increased blood sugar, glucose more specifically, causes an insulin increase secretion to keep the glucose down. Insulin tells your body to make fat and to store fat. You have the blood glucose go down, you feel hunger. In fact, do you ever notice that when you start eating carbs, you can't stop eating carbs? It makes you want to feed for it, eat more, eat more, eat more. And then when you stop the carbs, hunger is pretty much gone, because you're running on your body fat. You're running on your battery pack. Some people come in to me and say, I must be sick. I said, why? Don't you feel well? I said, well, I feel well, but I have no hunger. I said, well, is that bad? Well, the only time I've not had hunger is when I've been sick. Isn't that kind of weird? But it's actually, as you're learning, it's actually healing to fast or to not eat for a while. But then the energy and mood swings, this was I think, a major theme at the Metabolic Health Summit, which is the largest group of keto researchers and clinicians. It was held in Santa Barbara just a few months ago. And there were several psychiatric units now starting up called metabolic psychiatry. One at this little school in Boston called Harvard, and then I'm at Duke. So there's sort of a rivalry among, Duke's at the south and Harvard is up in the northeast. And there's another metabolic psychiatry unit at that school out west of Stanford University, young psychiatrists who are using this to treat not just low energy and mood swings, but actually real psychiatric disease that you would normally treat with medicine. It's pretty amazing. But then you get those carb cravings. And so how many of you who aren't eating carbs crave carbs? Raise your hand still. All right, so how many of you don't crave carbs? Raise your hand. Well, so that's a lot more. Look around. Yeah, because if you crave what you eat, right? What's remarkable is, ask me if I crave fruit. Just ask me, do you crave fruit? Do I crave fruit? No, I don't eat fruit. I mean, do you crave cigarettes? No. No, because you don't smoke. How amazing is that? So when you're talking to someone for the first time, and for you 4 people who don't want to be here today, you might even be saying, my fruit, my bread, my croissant, my Danish, anyway, enter your carbohydrate here. How could I live without... Red Bull. Wait, Red Bull? Wait, no. There's a sugar-free version of that. But you might say, well, I can't possibly do that diet because of that food that has carbohydrate. Remarkably, so think back when you got started. How many of you craved carbs for, let's say, 1 day and then all the cravings were gone? Raise your hand. So I think we're going to get kind of a bell-shaped curve. How many of you crave carbs for 2 days, 3 days, somewhere in there? How many of you crave carbs for a week? Raise your hand. All right, we're more like a curve like this. And how many of you still crave carbs even when you don't eat them? Oh, come on. Yes, of course. Yeah. But so I used to help people quit smoking, and there were some people who quit smoking 50 years ago, and they would tell me, I would love to have a cigarette today. Gary, keep your hand down. So you develop it's not worth having that, right? But it really boils down to this. And like we heard the professor say that it's not sexy to talk about glucose anymore, but it really can be that simple as a construct to think about things. Now, what is ketosis? What does that really mean? Nutritional ketosis, not pharmacologic ketosis, that's the SGLT2 inhibitor, not starvation ketosis, not type 1 diabetes ketoacidosis. That's not what I'm talking about. I'm talking about nutritional ketosis. Really what it is fatty acids are mainly used for the fuel, and ketones are used in place of the glucose. So it's really not ketones that are your major fuel. It's fat is your major fuel. But you can't say that, can you? So 20 years ago, we call these, high protein. No, we call them adequate protein, because if we said low carb, high fat, fat diets, we'd get in trouble. Now, you might not have ever had that problem here, but at least in the US. But then if you said high protein, you get into all of these. So adequate protein came out. But what I want you to remember is that you're really just a fat-burning machine when you follow a keto diet, a very low-carb diet. You're really just burning fat. So in that first bullet there, the reduction in dietary carbs signals the liver to use the fat and to convert the fat into ketones. Now, fat can be either from the food you eat or the body's fat tissue. If you end up over-consuming cheese and oils, there was a young man in the UK who actually over-consumed. He consumed 5,000 calories, which is how many kilojoules, or do you think in calories? So 5,000 calories a day for 3 weeks each, even on a low-carb, high-fat diet. He gained weight doing that. He gained weight on a keto diet. But he had to eat 5,000 calories, and he actually ate less, he ate the same amount, but he gained less than he gained on the high-carb, same calorie diet. So it's not just calories, it's about what your body does with the food, the hormonal response to the food that you eat. And I helped Sam Feltham publish his N of 1 trial, and I was guest editor of a journal, and I saw it on the internet. I said, you really got to get this published. And it really is out there as the straw man, or person, to show that this isn't true. So you could make a name for yourself as a student, a resident, a general person, to show that this isn't true. Debunk this, because a calorie is not a calorie. And it's shown in this one person carefully monitoring himself and in a publication. So the second bullet, in nutritional ketosis, there is no ketosis, acidosis. ketoacidosis. A very small amount of insulin will dampen the ketones. You don't get acidosis. If you have type 1 diabetes, which is insulin deficiency, and you're not taking your insulin because you're sick, you don't think you need any, or there's a mismatch, you might get ketoacidosis, but not if you don't have type 1. And then there's a top-off valve. Ketones are excreted in the kidneys, by the kidneys. A lot of people will measure for ketones in the urine as a sign that you're fat burning. So you can measure urine, blood, breath now, and I don't recommend that to any of my patients. They don't need it. And most of my patients won't do it anyway. So, but you can measure ketones. Now, I'm convinced, and you may need more evidence, but come to my office. Happy to show you what I do and show you some papers. I think it's safe and desirable to be in nutritional ketosis. The brain actually prefers ketones over glucose. The basic scientists have found that actually the brain sucks in the ketones. And if glucose runs around, well, okay, we'll take some glucose. But it's an active transport, not a passive GLUT1. And this is Stephen Kinane, the other brain researchers who are presenting their research at Metabolic Health Summit. And you know, babies are born in a state of ketosis. How can that possibly be bad? Now that might not persuade you, but if you don't eat anything, you run on your stored energy. If you don't eat anything, what do you burn for energy? If you don't eat anything, you run on fat. So if the default human fuel was fat, not carbs, how can that be bad for you? You know, the face validity of all the common sense kind of things are just, oh man, you know, you can say, yes, evolution and all that. No, but it's right in front of our faces. You watch this reality show, these reality shows, people volunteer to go out on this deserted island. There's a show called Naked and Afraid. Does it get into your... The naked part is they do take the clothes off, but they blur out the genitalia and, you know, but they, and the moobs, anyway. That was a funny term. I never heard that one. I've heard man boobs, but not boobs. But anyway, so naked, the afraid part is that there are snakes, there are bugs, there are spiders that'll kill you. So over 21 days, you go out there, you volunteer to do it. Most of these people are survivalists. They're trained to do it. They lose a pound a day of weight, reliably. So if you go to a deserted island, anyone want to volunteer? You can go, and I'll connect you. And you know, the bug bites are pretty bad, though. You want to be sure to watch one of these shows, but you will lose a pound a day if you don't eat anything. I mean, that's a minimum. What's the problem with that? Well, pound a day and you're a fat burner. You're using your body fat. It's that if you don't eat some protein, your body will use some of its protein to create the glucose that it needs. But so babies are born in a state of ketosis, and when you don't eat anything, you're in ketosis. So that must be really bad for you. Make sure you eat 5 times a day and take my medicines. No, the face validity is striking. I mean, how many things do I need to talk about to convince you that maybe this isn't so bad? So not all low-carb diets are keto diets, and this is in a paper that we wrote in 2007, which really defines what low-carb diets are. That's classic. You know, there's no definition of low-carb diets. Well, but excuse me, there is one. And now what people are saying is, your papers are too old for me to have in my PhD thesis. What? So yeah, I was told, I want to do a PhD on your work. I send my papers in. Oh no, that's too old. They won't let me use your studies. Oh, well, okay. But if you go under 50 grams of carbs, this is total carbs, not net, over the course of the day, about half of you will be in ketosis, 50 grams. Maybe a little more. This is not clearly worked out. If you go under 30 grams of day, 20 grams of carbs a day. You burn through all of your carbs and alcohol that you drink. You got to burn alcohol and all your carbs. Then your body will start giving up its fat. I mean, it's kind of like your fat is your retirement account. And if you don't have a retirement account yet, it's hard to get money out of your retirement account. There are all these rules and regulations. You need to pay penalties and all that. So you're trying to save this for the long haul. You got to burn through all of your carbs that you eat. So I start people at 20 grams per day or less. Because, if you came to me and you waited, right now the waiting time is 4 months to see me in my office, would you want to come in and say, hey, doc, what are you going to tell me to do? Well, this might work. If you do 50 grams of carbs a day, it might work. Or would you rather have, if you do 20 grams or less, this is going to work. First time, every time. Right, so you have to understand my perspective is in the sickest of the sick people, 20 grams or less will work. I mean, it'll work for you too, but you might be able to get away with 50. You're really active. You're like my brother. God, that your relative who can eat anything, right? Even in the same family, the genetics can be different. He eats over 100 carbs a day, lots of fruit. But he's out there playing basketball and doing all this activity, and he was always that way. So you may have the metabolism where I would rather read a book. I sat in medical school lectures while my brother was out playing college basketball. You see the difference? And it's not just that he's exercising. He's able to use those carbs, I think, genetically easier. He doesn't have the carbohydrate intolerance that I have the tendency toward. Popular diet books, and this is another confusing thing. Why do I have to learn from popular diet books and not my doctor? Well, you've heard already today all the different reasons why doctors they don't know about this. They think it's bad. Eating fat must be bad. But eating fat doesn't raise your blood glucose, so please don't say low-fat diets for diabetes. It makes no sense at all. So here's what I teach people. It's on one sheet of paper. You email me, you find me, I will send you this sheet of paper for free. If you go to my website, it's $9.99 because nobody values free information. That's the weirdest. I gave this out for free and nobody wanted it. And now that it's $9, so €9, people will pay for it. That's all. But anyway, you can just take a picture. And there's a little more detail on my handout, but essentially it's eat as much as you want of meat, poultry, fish, and shellfish, eggs. Eat a limited amount of salad greens and vegetables because there are carbs in there. And then there is a limit on the high-calorie items like cheese, creams and oils, and mayonnaise. And I'm going to show you the main difference of what people learn on the internet and between this kind of approach in just a minute. A lot of people talking about sugar, and this graphic I think came from David Unwin, Dr. Unwin in the UK, who's made a lot of rattled a lot of cages because he showed he could save money doing this in the health system. He showed that he could get people off medications, and the dollar matters, the euro. So a banana though has 4.25 teaspoons of sugar. A Coca-Cola has 10 teaspoons of sugar, and the comparison here. I don't have my slide of, you only have 5 carbs in your bloodstream, 5 grams of sugar at any given moment. If you pour out your, do you use milligrams per deciliter or millimole here? Millimole, so that would be 6 is a normal blood glucose. So I'm looking at the medical students for validation, but so 6 millimole, you multiply that out, there's about 5 liters of blood in an adult. There are 5 grams of glucose in your blood at any given moment. So if you drink a Coca-Cola, let's say swig it, and you're pouring 10 teaspoons, so that's 5 grams per teaspoon. So that's 50 grams of sugar into a little place that you're called your blood that only has 5. So you wonder why the blood glucose goes up after drinking sugar, like a Coca-Cola. Wow. There's only 5 grams of glucose in your blood at any given moment. Does that make sense? Am I communicating that well? So you would never really want to eat anything that had more than 5 carbs at a time, at a given moment. Of course, you know the rest. No grains, no pasta, no... Credible. I should have tailored my slide. No fruits, no nuts. I'm not a big food quality police person. I had someone lose weight just eating at a fast food establishment that starts with an M and a C, and just ate burgers, no bread, no buns, no French fries, no sugar in the drink. He lost 100 pounds eating at McDonald's. Wow. So I'm not a big food quality. If you can do it, great. If you can use every dollar to change the food environment, it's great. But here's my kind of wrapping up the medical establishments. You do have to unlearn just about everything we were taught. So here, you went on keto and lost 90 pounds, lowered your cholesterol, cured your high blood pressure, and now you're walking 5 miles a day. But I'm warning you, a low-carb diet is bad for you, a keto diet is bad for your health. So just expect that that's going to be the response, because they don't know. We even had a young medical student who started erasing people's memories for the old way of things. He got it from the Men in Black movie, you know, where they erase the memory, but you don't need one of those. Bonpuri paper, if you want the best paper that shows the metabolic changes on a nutritional ketosis kind of plan, this is the one, Bonpuri 2018, and everything is better on this slide in the direction you want, except one thing, and that's that pesky LDL. So don't worry about the LDL. The old way to look at the lipid panel is look at the total cholesterol and LDL. The new way is to look at not just the lipid panel, but the triglyceride, the HDL, the abdominal circumference, the blood pressure, and the blood glucose, and you're going to do better than just looking at that total cholesterol. So keto addresses insulin resistance and metabolic syndrome. You saw kind of a version of this slide in Amy's lecture, and that's on the far left, there's strong evidence. On the far right, there's evolving evidence for these things, and we're following all of these. I have to be medically meaning clinical trials to support what I say and use in my practice. So I don't say this cures cancer. If you want to use this and you have cancer, great, but I'm not going to make any guarantee or statement about that because there is not clinical trial evidence for that. And we heard a very provocative talk today about Alzheimer's and minimal cognitive dysfunction and neurodegenerative. And it's fascinating. It's still theoretical, though. So I'm an internist. I have the sickest of the sick people who are still walking ambulatory. This is one of them. She had severe heart failure. On the bottom left, she had an ejection fraction, EF means ejection fraction, of 20%. Her weight was 310 pounds, so that's 150 kilos. So she was hospitalized for heart failure. It's like shortness of breath, can't breathe. She started to lose weight, hit a plateau. She came to my office. We continued to help her. She's an ICU nurse at Duke. And now she's down, I don't know how much weight, a lot, 140 pounds. And her ejection fraction, the squeeze of her heart, has improved from 20 to 50%. So can your diet, drug, whatever, fix heart failure? You know, this is not just it's not a dietitian's diet. This is medical therapy. Remember, food is the key. How could this be? Well, it turns out the heart prefers ketones and fatty acids. So on the left, let me do that away. Say that again. The heart prefers fatty acids and uses ketones over glucose. Well established. And on the far right, insulin resistance is actually the root cause of heart failure in the established papers, but the cardiologists haven't made the link between insulin resistance and carbohydrate consumption, because then they have to get through this paradigm shift of, that means I have to tell people they can eat fat. So don't expect a cardiologist or a traditionally trained doctor in the low-fat idea to understand this. If they want to, they can. So internet keto, let me just finish with a couple slides. I know I'm going to go over. So the internet keto, I thank Amy and her friends for this a very perceptive slide, which today on the internet you might learn about the ketogenic diet for epilepsy, and people will be confused, and you'll think that that's what you use to treat obesity. No, you don't have to focus on macronutrients and macro ratios. You don't have to focus on ketone levels unless you have epilepsy. Paleo Primal, the food quality movement's done a great service, I think, to real foods, but you don't have to have that high food quality, and this can still work. So what I'm talking about is LCHF, but we couldn't say high fat, so Diet Doctor came up with LCHF as the smooth way, and LCKD is the way we said it, low carb, keto. We focus on carb restriction and total carbs, not net carbs. So we did a couple of years, we've done internet teaching, we surveyed people on the internet who learned the internet keto and then put them on our brand of keto. In the 2 surveys, they lost over a ton of weight. Self-report, yes, because it was internet. We taught people on the internet. They told us in just 3 weeks how much weight they lost. And you add it all up, it's over a ton. And several of you were in these classes. Thank you. And here are the big things that I just want to end on that you don't have to do, but it's what you might have learned by reading about this on the internet. You don't have to measure ketones. I never ask people to measure ketones. You don't have to calculate a macro. Remember, this was designed and first talked about in 1860, before there were any apps, before there was a computer even envisioned, probably. So you don't have to calculate macros. If it gets too difficult, just dump it, You don't have to have medium chain triglyceride oils or ketone drinks or pills. Remember, ketones come from your own body fat. You don't have to drink oils and have that to get ketones. Fasting is not required. Now, it can work, just like the Naked and Afraid fasting for 21 days, not eating anything, it can work, but it's not necessary, and we wonder that maybe you're not going to get enough body protein to support your muscle mass, and that's research I'd like to see. Show me 50 people on intermittent fasting, different approaches, and publish it in a peer-reviewed journal. I'll comment on it. You don't have to fast. If you're not hungry, don't eat if you're eating still once a day. That's how we teach it. Nuts, nut flour, and nut butter are not okay. And this is probably 50% of folks will have trouble with nuts. And that's enough in my office, in my practice, to say no. Because you might have trouble, but you won't. But oh my gosh, half of you will be angry with me that my approach didn't work. So I teach people no nuts, no nut butter, no almond flour. It's very popular. Vegetables are not unlimited. They have carbs. 2 cups of leafy greens per day, 1 cup of a non-starchy vegetable, roughly the size of my fist, and that's plenty of vegetables. Use total carbs, not net carbs. Don't know if that's percolated into your world. I checked just a few of the junk foods in the vending machine out here, and it looks like total carbs is listed there. You don't want to look at of which are sugars, just look at the total carbs on your nutrition facts label. Artificial sweeteners are not forbidden. In fact, I need them to get people off sugar if they're true sugar addicts. So it's okay to have these artificial sweeteners when you start out, okay? Expensive clean food is not required. We have these fancy markets. They put organic on it and they charge 5 times the amount. You can go from eggs, $1 per carton to $5 per carton, and the chickens look like they're cared for a little better. I don't know. It's still the same kind of food. And I'm sorry to tell you, here in the Netherlands, cheese, fats, and oils are limited. If you're getting started, there's a lot of calories in there, and so these are things that we were able to correct in people, what they learned on the internet, change to our approach, and if any of these things apply to you, you don't need us to tell you that. You can just try those on your own. So the last thing I just want to say, if you have medical problems on the left, you're on insulin, other blood glucose or high blood pressure medicines, don't do this by yourself. You can get into trouble with low blood pressure, low blood sugars. Find someone who knows the keto approach to help you do it. Otherwise, if you're on the right, you can do this on your own. It's just food. Read up on it. You can do it on your own. But I found that I save people time. There's so much information on the internet now. If I can focus your teaching, it's just going to be more efficient and save you time and maybe money. So science-based keto, there's a lot of data, a lot of research, a lot of randomized trials going back over 20 years now. The science really says that low-carb diets, including keto diets, are safe and effective. Beware of other products and methods that might impair the use and even safety. I don't know. When the SGLT2 inhibitors came out for heart failure treatment, I started seeing ketoacidosis in my patients. I'd never seen it before because that's a side effect of the medicine. That medicine can cause ketoacidosis. So another way to think about internet keto is like over-the-counter medicine you can get at the pharmacy. It'll work for some people, but not everyone. This evidence-based keto is like prescription strength medicine that you have to get from a doctor or with a prescription from the pharmacy. And then please get monitoring if you have medical problems. Thank you very much. Remember, the secret is right there. If you eat carbs, you got to burn them. That's it.
Thank you very much.